Yeah, that's
Yeah, I know. Yeah, I think it'll be okay. We'll one way or another. The stressful bit is last night when you haven't written any of your talks and yeah. So, but I've done most of them now. Thank you. Okay, order. Okay, can I call you back? Okay, good morning. Ready for the second session. Okay. Everyone, can I get some quiet so we can start the second session? So first thing to say, how wonderful it was to go into the coffee room and see everyone chatting and networking and making use of the break. Second thing to say is I don't know what possessed me to think I needed to encourage any of you here to do any of that because it was all going on vibrantly. So that's great. Okay, so we'll crack on with the second session, and the second session is focused on elimination in prison. Prison, I can't remember now. Yeah, prison and some probation testing. So I'd like to welcome Anya Hughes from HMP Berwyn. Oh, there you are. Who's just spawned behind me to give the first talk. Thank you very much.
So how we achieve microelimination in Berwyn. So me and Janessa sat down and went through over 2,000 prisoners' notes. I made a list of actually who needed a test. We were using mouse swabs beforehand, but then we decided to go through a full dry blood spot test and retest everybody. Obviously, while doing that, we studied that we have about 60 to 70 people in a week, so we need to see, like, keep on top of it. So we made sure primary care were testing the new arrivals during the initial screen. So this is reviewed every morning for the people that come in the night before. So I go through the list of names, and if they've declined, they'll go on to band force to go out and get them. We started mini mass testing in the gyms, wings, and workshops. Then the peer program started when the Hepatitis C Trust joined. We use the peers to overturn declines and assist with testing and training. We provided prisoner and staff training, and we gave prisoners a chance to promote their own health, so them encouraging their friends to get a test. So these are the statistics that we collected for the microelimination announcement. So we had a roll of 1,963 prisoners at the time. 1,852 of these had a test with dry blood test. 35 people didn't want that and had an oral mouth swab instead for Hep C. There was approximately 364 PCRs completed in those 12 months. 41 of these are positive for hepatitis C. In September, 95% of positive patients started treatment and 100% in October, November, well, to this date, actually. So So October to January, we had 78% uptake of dry blood spot tests during the first night screen. Then we had 93% uptake within 7 days, 95 within 14 days, and 96% 14 plus days. We had 13 arrivals that left within 7 days to ensure if they really count or not. So also this is the data from the Hepatitis C Trust from October 22 to February 2024. So you can see the amount of peer hours that the actual peers did there, the amount of leaflets, in-cell work booklets, peer interventions, and that's like decline over terms was 540. So this is our testing pathway that we use. So new arrivals who have had hepatitis C before, because I review people that come in the night before, I go through the past medical history. So I would go and see them the next day for a rapid PCR while we wait for a dry blood spot test to come back. If they're negative and they've been putting themselves at risk in the community, they'll get a repeat test and a rapid PCR 3 months after arrival. And then if they were negative again, then they'll have it 9 to 12 months after being in. Also new arrivals, they have a dry blood spot test in reception. They take about 4 to 10 days to get the results back, and then the rapid PCR is obtained if they were positive. And same really applies for the 3 months and the yearly there. If they're scared of needles, they will decline in reception, and then they'll be booked at healthcare for a mouth swab, and then same applies at the bottom there. And if they decline in reception, they're seen in the next few days of arrival with the hepatitis C peer. Education and harm reduction is given and re-offered the test. And then obviously if they decline, it's the same, and then they try again like in 12 months' time. So treatment pathway, sort of diagnosis, fibre scan, pre-treatment bloods, MDT with pharmacy, which is Sarah and Liz, treatment start, ongoing regular support, and then treatment complete. Hopefully. How we're maintaining it is primary care reception screening opt-out is being monitored every day still and followed up. The SMS band 4s are now going out to see people who have declined, and also picking up did not attend in healthcare for 3-month to 12-month dry blood spot tests, training the band 6 SMS nurses to complete CEPI PCRs. Primary care now doing 2 afternoon clinics a week for 3-month and 12-month tests. SMS doing 1 morning per week. So maintenance. So when we reached micro-elimination, we thought it would all slow down, but we were wrong. So in January, there was approximately 327 dry blood spots taken, 27 PCRs, 6 positives. February, there was 383 dry blood spot tests, 28 PCRs, 1 positive. And in March, there was 392 dry blood spot tests, 28 PCRs and 7 positive, which is basically a quarter of the PCRs. So the actual breakdown for the testing. So if you look on the right-hand side there, so FN's on the first night, OT is the overturned, the 3 monthlies, 12 monthlies, and RQs requested. So the issues, so at the moment, obviously there's a overload in prisons, so they're transferring prisoners left, right and centre. So people are getting transferred like twice a month sometimes, and they decline when they come in because they don't really need one. So then also that can affect your stats. And obviously people now with the early release scheme, people getting released early, coming back in the same night, the next day because nothing's like set up for them. So they haven't really put themselves at risk. So that's what get declines from as well. We haven't got an official peer programme running currently because the funding was unfortunately pulled for the HEPC Trust. So officer and prisoner training has been put on hold due to staffing. So we lost Janessa and Neil, our 2 full-time members of staff. We're seeing more resistance and failed treatments with prisoners coming in, so it's taking them longer to get onto treatment. And more people are likely to decline their yearly test because for the harm reduction and that we've done, a lot of people are actually buying their own razors and hair clippers and stuff. So like, well, I'll just use all my own stuff. So it's like, well, I don't like really need one again, but obviously prisoners released from court, if they go to court and they're on treatment, they can't transport meds, even stuff like insulin, to their court. So when they get released, they can't have anything with them because of the guidelines of GOAME. So that's something that's getting looked into because it's happened like twice recently for us, and we can't find them in the community either. And obviously we get a lot of last minute releases, early releases that I don't know about. And I go to see somebody, I'm like, oh, well, they left yesterday or they left this morning. So they're not getting left like with their letters and referrals like they should be. For the positives, we obviously achieved micro elimination and managed to maintain it for 6 months, despite unfortunately losing 2 full-time members of staff 2 months ago. Our abstract of the work we did at HMP Berwyn got accepted and presented at the World the Hepatitis Summit. So newly appointed Band 4 is due to start in June 2024. And we've also got an admin to do the admin for the service as well. We've not had any new hepatitis C positives on the yearly test since doing micro-elimination. I think we found 1 during micro-elimination that had already been in the prison. So all in all, it's all the people coming in. Any questions?
Anya. Have we got a bit of time for questions? Any questions for Anya?
The head of healthcare decided to pull the funding.
Is it health board?
Yes. So for hepatitis C trust. So instead they've put a post up for the Band 4 instead.
Replacing one.
Yeah.
Lower level.
Yeah.
Loads of a quick question. Well
Yeah,
done.
Thank you.
Can I just ask, something that came into my head, the job they're doing, how many English prisoners and how many Welsh prisoners tested?
I think there's probably a lot more English prisoners in there at the moment. Normally. It just depends really, because like they do like lockout.
Looking at the Manchester end up there.
Yeah.
How many actual Welsh prisoners were treated and tested?
Yeah. So
I thought were.
yeah, so we do receive a lot of them, especially during like certain weeks when they do like safeguarding lockouts. Then we have all the Northwest, so we even get like Wigan, Blackpool, all up those areas that come into our prison. So it's kind of hard sometimes because in English prisons they're so quick to put people on treatment. So we have lads that have come in and out of like English prisons, started, and then not carried on in community, gone back in, gave it them again, and then they're coming to us then with resistance because they've never actually finished the course. So it's sort of having to work with individuals rather than hitting stats all the time sometimes. It's okay.
Yeah, Nikki.
Yeah. Yeah, I know it's getting in. That's good. Oh, that's great.
Okay. Just before you go, again at the beginning we talked about money and people, and I think that presentation demonstrates really clearly why it's people that is important in terms of delivering elimination. And Anya will probably be a bit embarrassed for me to single her out because it was a team effort, and I know she'll be the first to recognise that. But I'd also just like to say massive congratulations to Anya, because she's really driven elimination in Berwyn Prison from the word go, starting from what were you employed in as initially? As an SMS nurse initially, and now you're the BBV nurse within the prison. So just to show our appreciation for what Anya's achieved. Okay, so moving on from Berwyn to Swansea, and we like eliminating in Swansea so much we've done it twice. So over to Darren Matthews.
Okay, for those of you who don't know me, my name's Gary Matthews. I'm interim healthcare lead at HMP Swansea. Just a little bit about Swansea to start. It's a Cat B C remand prison with an operational capacity of 500, but our average stay is 6 to 8 weeks. So our pilot, we were approached early 2019 by Public Health Wales to start talks about Swansea being the pilot site to eliminate hepatitis C. So we developed a pathway and we opted out of the opt-out testing, And the pathway developed included the testing, the referrals, and treatment options. So trial commenced in May 2019 with a very small team of staff, with those staff members consisting of Public Health Wales, the local bloodborne virus team at Singleton Hospital, and a handful of staff within Swansea Prison. And by September 2019, we declared micro-elimination, this making Swansea the first remand prison in the UK and the first in Wales to achieve this. So as a team, we decided on a set of read codes to make reporting easier. We created auto consultations within System 1, so we ensured everyone was using the same read codes, which reduced the documentation time. And these are a selection of the read codes that we came up on for mouth swab testing, and the same for our PCR testing. And we also hold an additional clinic every Monday for those who've refused first time round or ones who were back in court the following day. So how do we achieve the elimination? Between May and September 2019, we offered 596 mouth swab tests. 503 of those were non-reactive, 78 were reactive, 15 refusals. That's just a breakdown on the graph. 84 men were offered PCR testing. We initially had 4 tests aborted and no results for 2 of them, so we retested them. And out of those 84, 47 were not detected. Excuse me, 27 detected and all commenced on treatment, and we had 10 refusals. So our total testing figures for 2019, following our declaration of micro-elimination, we offered 1,019 mouth swab tests, and we had 106 reactives. We had 2 invalid tests, which we retested, and we offered 125 PCRs, with 48 detected, 13 aborted, and we had 1 released before we could test them. All the aborted tests we retested, and we had 4 tests from the community because they were in with us and they wanted to SVR testing, so we done them from the community. 2020, only 46 mouth swabs offered, 32 non-reactive, 3 reactive, 11 refused, 3 PCRs offered. 2 were negative, 1 was tested and commenced on treatment. We then had to hand back our machine to Public Health Wales for them to use it for COVID-19. And then we spent 14 months testing different people, providing evidence that we could leave our houses, and spending hours, days clapping for people. 2021, we resumed talks with Public Health Wales to reinstate their point of care test in the Swansea prison. By the time we got through security procedures and got all the paperwork in place, that commenced in May 2021. We only tested 694, but luckily we only had 21 reactive tests. And we'd done 74 PCR tests with 23 detected and again 6 aborted. However, we had 3 requests from the community to PCR. We had 21 started on treatment, and the 2 that released before we could get them on treatment, we contacted the CNSs in the local health boards to provide them with the results to commence treatment. 2022, a bit more this time, 1,527, 154 reactive, but we've done 164 PCRs. We had 37 detected and 13 aborted, and we had 2 cartridges expired. However, 5 of those reactive tests were released before we could PCR them. Again, we contacted communities to pick up them for us, and then we retested the 2 expired cartridges and the 13 aborted tests. However, everyone else who was detected started on treatment. 2023, 989, 62 reactive, 11 detect and 11 invalid. 77 PCRs with 19 detected, again, high percentage of aborted tests. All 12 were retested, and we also had an additional 3 requests from the community. And say all detectives start on treatment again. 2024, this is up to and including the weekend just gone. 422 tests so far with 32 reactive. 34 PCRs, 7 detected, 6 refused, 2 aborted. We've retested those 2 aborted, and all other detectors have started on treatment. So how do we support Public Health Wales in providing ongoing testing within HMP Swansea? Develop communications again with Louise regarding our current training procedures. Between us, we developed a new approach to training. So Louise or Morgan from Public Health Wales arrange virtual training sessions, and they run through the point of care theory element with the staff. I then meet with the staff and undertake the practical parts of the training in clinic and arrange a follow-up clinic. So then Louise or Morgan can complete the final competency check in the coming weeks. So at present, we only have 8 staff who are trained in mouth swab testing and 2 staff for PCR testing. However, since the pilot began, we've trained 24 people for mouth swabs and 3 for PCR testing. So sharing some experiences and knowledge. Prior to HMP Berwyn, which you just heard about, we had a Teams meeting with them and we shared our experiences and read codes. So we were sure that everyone was using the same. HMP Cardiff staff have attended HMP Swansea to oversee a clinic to see how it works in principle. I've created auto consultations and read codes within Cardiff's System 1, so we're using the same data. Once I've had access to HMP Park, I'll do exactly the same for them. And we've developed links with wider health boards and clinical nurse specialists. Thank you for listening. Any questions?
Any questions for Gary?
No, happy days.
Stay.
Where there's transfer.
Yeah, it's a lot of turnover. Some have always go out today, back in tomorrow. So we'll retest them tomorrow and they'll be on our figures, but they will refuse. But we've got a data, we've tested them 2 weeks ago.
Yeah. So is there a way of recording not required? Do you know what I mean? So that you can...
So one of our read codes, and there's a bit of work going on with Nikki from Public Health Wales as well, that we've got history of read codes going on the system now, and then hopefully we will develop the service going forward.
This is one of the issues that Lee was asking a question about earlier, which I closed it down because we were a bit short of time, which is how do we stop the treatment goals getting in the way of identifying what we're actually trying to achieve? Because we don't want people to be tested repeatedly when they don't need to be tested. That would be the wrong outcome. So we do need to do some work around that so that there is an ability to record that tests not required. What we've got to be a little bit careful of is that when you have an out, it's potential that can be abused. Yeah, it's about trying to get that system working. I don't know if Lee, you've got any thoughts around what should or shouldn't be happening in that regard, because I did shut it down a bit earlier. Yeah. Okay, we haven't got that long. Okay, so yeah, something that we need to work on essentially. I think, did you have a question?
Yeah, so if they're on treatment, we give them the treatment to go out with them, because we've got the courses in the prison. So then if we start someone on treatment, we'll contact Singer and they'll send us a new set of meds, but they go out with them. 9 times out of 10 they come back without them, but they go out with them. No, we know most of ours, we know go. We do have the ones that get released from court, but we're quite lucky. Swansea courts are only just up the road from us, so they come back to us to get their meds. Yeah. Earlier he said that's caused us issues.
Yeah, thanks. And similar to Anya, Gary's been instrumental in delivering elimination in Swansea, so we should give him a clap too. So next up, Morgan Cutland, who's going to talk to us about probation testing, test and treat in Swansea.
Hello. So my name is Morgan Catlin. I'm a national POCT practitioner. That means point of care testing at the Wales Specialist Pathology Centre, Public Health Wales. And today I'm going to be presenting on a project we did last summer in Swansea Probation Delivery Unit. So this was our testing room. As you can see, we're all geared up to test absolutely anyone that walked through that door. So a little summary, this was a pilot project. It was the first of its kind in Wales, screening for viral hepatitis, HIV and syphilis. We used DBST and POCT. I'm sure a majority of you have had your fair share of finger pricking, but a DBST is essentially a little card, 5 drops of blood, test for Hep B, Hep C, HIV and syphilis, goes back to the lab, which will get processed. And then with the POCT, we use essentially a lateral flow for Hep C exposure. That gives us a result after 20 minutes. Any reactives would then get followed up with our little gene expert cathode, that would give us a result for Hep C after an hour. We would then refer the patients the same day to James Plant and Paul John, who would get the medication train running. We saw 439 patients in 18 days. The project ran for 5 weeks. And prior to the pilot, Louise Davis and James Plant went into probation just to give a little bit of training to the probation officers, just so they knew what we were doing and why we were bothering their people on probation. Oh, and in the previous picture, that wasn't a patient, that was Ryan and James. I need an entire presentation to mention everyone who was involved in this and thank everyone. But on this slide, I'm just focusing on the people who did the testing and the treating. I should have added Paul John in that. That's an admin error from me. Sorry, Paul. But we had a multidisciplinary team with the Wales Specialist Pathology Centre. We had Louise Davis, who's a senior biomedical scientist, national POC lead. We had Ryan Davis, who's a national POC practitioner, like myself, and we also had Sam Ray, who is an advanced nurse practitioner. We also worked with Swansea Bay Health Board, where we had James Plant and Helen Thompson-Jones, who are both CNSs, as well as Georgie Vanderbilt. And I don't know if anyone remembers last summer, May time, but there were more bank holidays than I've ever known in my life. So we had this rota to make sure we always had cover. We always wanted to have at least 2 people on site. You would have one person then able to focus on the testing and another person kind of ferrying in these people for their BBV screens. So this is the room, and as you can see, our testing room is right by there. It was fabulous having a room directly off reception. This kind of worked in a way that encouraged people to engage. They'd see their friends and people going in, coming out, all limbs intact, and some of them even had a smile on their face. So that definitely helped with engagement. We'd have a little sales pitch, which we'd kind of go out. Sometimes you'd see Lou slide on this sofa and say, "Hello, my name is Louise Davis. I work for the NHS, and today we're screening for viruses that attack your liver." We quickly learned that saying words like hepatitis, HIV scares people. And as soon as you say these words, they're like, "Nope, I'm not going anywhere with you. I don't inject. I'm not, no." So we just thought, if we say viruses attack your liver, obviously when we go to test them, we'd explain what we're actually testing for. But that definitely helped with engagement. We noticed a ripple effect. If one person said no, you know the next 5 you ask in are saying no too. But then it also worked positively. If someone said yes, the rest of the people might say yes too. A lot of you are patient facing, you know the reality of it. Working with people can be hard. You don't know what kind of day they've had, what kind of life they've had. There's a lot of things going on. It's not just so simple as perfecting your sales pitch. Sometimes you're not in the mood, they're not in the mood, but you've got to put a face on and, you know, go about your day. A lot of these people, terribly vulnerable. A lot of them just come from prison. They're their heads all over the place. The last thing they want is you coming over to them being like, "Hello." So that definitely struck the reality of what we were doing. This was also a benefit of being there for such a long period of time and having a prolonged presence, because some days people just wanted their bus fare and their Greg's voucher, and other days, not that we were giving them, that's in probation, give it. And they would come back later on, maybe a few weeks' time, few days' time, and say, sorry, I wasn't in the mood the other day. Is it possible to have one of these tests? So that was definitely an advantage of the long window we had. We also wanted to use non-verbal forms of communication. So we had posters and handouts. These are some of our engagement tools. As a team, we obviously want to test everyone, but sometimes that's not a reality. And we try and at least give some kind of positive BBV interaction by talking about harm reduction, ways that they can transmit the virus, just educate people a little bit that there is treatment available, get a test, we can sort it, it's fine. So definitely an advantage having something like this, which had all the transmission routes that we could think of. If someone said, no, I don't want to test, we'd say, cool, that's fine. Just do you mind if we hand you this? Have a little read whilst you wait for your probation officer. If you change your mind, we're just in that door. You'd see people go down the list, their eyes widen and think, oh, maybe I should have a test. So that was definitely good for engagement too. You don't have to read all of this data. This is just kind of like a snapshot. If you've ever worked with me, you know I'm ridiculous about my data and my data recording, so apologies. But we logged everything in regards of how many people we tested, what kind of tests they had, and what the outcome were. As we were doing 2 test sets, one which was the rapid POX that we'd get the same day, and the DBST that would take a few days to come back from the lab, we would be able to document the POC at the end of the day, but then kind of look on our management system, our LIMS management system, to look up the DBSTs. Initially, we wanted to log everyone that was coming in. It quickly became apparent this wasn't possible, as you had people coming in with their friends, families, pets, snakes. You had key workers. It was really hard to tell who was actually showing up for an appointment or who just fancied a trip to probation on a Monday afternoon. I know one guy definitely got asked 5 times. He said no every time, but we just had to keep on asking everyone. And I know I accidentally asked a default key worker or 2 if they wanted a test. If you're here today, I just had to ask everyone. I'm really sorry. And so this is a little bit more data. We performed 392 DBSTs and 359 oral swabs. But the uptake was actually quite equal between those 2 test sets. If someone came in and we said, have you been exposed before? We'd fast track them to a PCR because that was a more appropriate test for them, rather than them kind of going off and having to get another bus fare back. So it was equally accepted. We found 9 infections in total, 6 HEPC, 1 HIV and 2 syphilis. And the number of tests performed were 826 on 439 patients. So this little graph is showing the volume of tests performed each week over the 5 weeks we were there. As you can see, in the first 3 weeks, it increased. I think that was obviously a lot of factors to it, but in my opinion, I think people seeing us and getting familiar with us and that trust definitely helped. And I also think, I don't know what else I think, I've forgotten, I'm going to ignore that. In the 4th week, then we had half term, so a lot of the probation officers weren't in, therefore there weren't as many appointments, not as many people coming through the door. If someone's not there, we can't ask them for a test, we can't bring them in. And then the 5th week, that monthly cycle in which their appointment system works would be complete. So a lot of these we'd already tested. Some people came in for another test. We were like, loving your enthusiasm, but you can wait a little bit longer. So that was fab. And oh God, what's that? So on our referrals, we had James Plant, who was our little Superman. He managed to get 5 out of the 6 people on treatment with an average of 3 weeks between diagnosis and starting treatment, with the help of Paul John, our pharmacist, I believe they're called. All of them have achieved SVR, which is fantastic. The one person outstanding, I believe she was a historic case and she's just not in the mood for treatment yet, but I know James has got her on his list of 2 to be started. Something's in the works there. And then Swansea Bay Sexual Health Team, who were located directly opposite probation, which was super helpful. They treated both the syphilis and the HIV patient. So a little evaluation, 56% of people had no prior BBV testing. So it definitely shows this was a worthwhile location to do the testing. All infections were referred to the CNS and Swansea Bay Sexual Health Team. 88% have completed treatment. The key worker engagement, as always, was so essential. Non-verbal engagement tools is very useful. DBST were equally accepted. And having that room opposite the reception was brilliant. And Georgie goes in fortnightly to make sure that we're still keeping a presence for DBSTs. If you've loved this presentation, loved the whole thing, there's a whole report online. Anyone can read it. I think Lou was doing signed autographs at the end. So that's available online. It's by Dr. Steph Perrett and Dr. Benjamin Gray. Thank you all very much for listening, and thank you to all these people and everyone else.
Okay, thanks, Morgan. Another phenomenal piece of work. Oh, don't go anywhere. Any questions for Morgan?
Substance Use Commission Services and HEPC's Commission Services Department. Are kind of those tests, are they being reflected on the harm reduction database? Are they being logged on there? Just because I'm quite conscious that's a massive number then that would potentially feed into the KPI figures.
Yeah.
So it's not reflected on there, then that's going to miss. And
so to refer to one of the slides, I don't know if you saw that superhero. So James Plant, he's been doing all of that. So yeah, that's being done.
Any other questions? Hang on there. So the work that Morgan and Ryan and Louise are doing, obviously, what we've seen there is their foray into probation, but they are actually a sort of HIT team, a high intensity test and treat team. So opportunity in the break and what have you to catch them and think about where else we might deploy such a team. And also one thing I'm keen on is perhaps replicating that model in health boards. We're trying to get 2 people dedicated within Swansea so that they can carry out high intensity test and treat on a rotational basis, really helping to sort of kickstart testing within an area, which then can hopefully be maintained. That was one thing. And then just to pick up on the harm reduction database, because I know, Josie, we didn't really have time to pick up on it at the end of your talk, but it is clearly really important that we do get the data. It's great that we've got a sort of stripped down version, which will hopefully be more manageable for people who are working under busy circumstances. You know, with the one that we need specifically around injecting drug use, I know we need all of them. Is the one around injecting drug use, is that do we need that more than the others, or are there reasons why we need the others as well?
Just achieving that target. There's a sort of compromise to be had. We need the sex, the prison, and the drugs.
We need them all, yeah. So there's no okay, I was just thinking. Yeah, which is great. I was wondering about mandating answers, but you have mandated them. Okay, I'll shut up. Okay, fine. I'll shut up then. Okay, Morgan, thank you ever so much. Okay, and now we're going to see what happened in Anira and Bevan in probation. And thanks to Beth and Bowden. Thank you.
Hi everyone, I'm Bethan. I'm one of the consultants in public health in Anira and Bevan, and we had the opportunity to take a lot of the learning from what happened in Swansea Bay and just try and make it work for us in our area. So, move me on, just moving me on. No, get the technology to work in a second. There we go. So just to give an idea, I'm from public health, so this is the bit that we started off with, not from necessarily the clinical perspective. So when we were pulling together our response to the Welsh Health Circular that Brendan referred to earlier, we looked within our joint recovery plan across 5 broad themes of how we wanted to incorporate those different actions within the Welsh Health Circular, and how we were going to deliver that in Gwent. So one of our key themes was around increasing testing within high-risk groups. To paraphrase slightly, but Gavin, who's our BBV lead, basically said, Bethan, if you test more people, I'll treat them for you. So that was essentially the model that we're working with. How do we bring more people in to test them and then get them through the treatment pathway? So we'd identified, as you can imagine, when we're looking through our high-risk population groups, people in contact with the criminal justice service and the criminal justice system are going to be key people that we're going to want to target. So we'd identified custody suites, we'd identified probation services and prisons as those 3 sort of key areas. What was a real key for us was developing a really positive relationship with our probation service locally. So big shout out to the probation service, who've obviously really focused on health and wellbeing, and we have a fabulous health and wellbeing partnership coordinator who we linked in with really early to try and identify what were our opportunities from a health and wellbeing perspective to maximise those outcomes for people who are on probation. And one of the things that came up was, do you know what's been happening in Swansea Bay? And one of the things that been happening in Swansea Bay was the BBV testing programme. So we literally standing, I'm not going to say giants, because obviously Morgan is very petite, but we were standing on the shoulders of what happened in Swansea Bay. So we decided that we wanted to do the same thing because it sounded like a great idea, getting a really great identifying a population group who weren't otherwise going to be tested. So we were looking at planning a high intensity testing event ourselves. It was also an opportunity for us to think about how we develop that collaborative partnership with probation, thinking about how we develop and strengthen those relationships with our probation colleagues and what other opportunities we can have to address some other health and wellbeing outcomes. So why did we go for Newport? So in Iron Bevan, for those of you who don't know, is sort of this sort of Gwent area. So it covers 5 local authority areas. But we went for Newport because it's got the most hepatitis C that we can see in our area, and it's got the biggest footfall in terms of people coming through probation. So that was a fairly easy data analysis question. As I've sort of mentioned, we've got these 5 key themes. One of our key themes is around collaborative working, partnership working, and I've already alluded to what was really key for us was developing and strengthening those relationships with probation as our partners. So I guess one of the key learning things from us is that these things take time. So we started some of this conversation back in the summer. We then had a series of planning meetings and became more detailed planning sort of going into the autumn with the intention to run our pilot in the new year, in the January and early January, running through to February. So it was a really collaborative effort. So from a health board perspective, we had our BBV clinical nurse specialist, who was absolutely crucial in terms of being able to deliver this, ourselves within the public health team, and also our health protection team. So that includes our healthcare support workers who've been trained to undertake dry blood spot testing, who were able to support and undertake the testing in collaboration. So we work really closely with Gwent Drug and Alcohol Service, particularly their BBV clinical lead and the criminal justice team who work within GDAS and obviously probation. So we were going to go for 4 weeks. And we decided that because Swansea had already identified, I'm paraphrasing a little bit here, but essentially it didn't really matter which test we did. All of our healthcare support workers had already been trained to undertake DBS testing. So they'd already gone through that training process. They were familiar. We had protocols and processes in place. So we decided that we were going to go just for DBS testing. So we had to do as you'd imagine, some of those initial site visits, figure out, oh my gosh, floor coverings. I never want to hear plastic floor coverings, but we have to think, ensuring it nearly derailed the whole project. But we had, thinking about from a health and safety perspective, our health protection incident practitioners worked really hard in developing our SOPs, our information leaflets, and establishing the database so we could have some data collection and be able to show some outcomes at the end of it. Our clinical nurse specialists and our BBV lead within GDAS as well went and delivered training beforehand to probation staff, so they knew what they were what we were testing, why we were testing, and all the purposes of it. Our healthcare support, because we were doing DBS, we were also testing for syphilis this time, so we had to do some additional training for our healthcare support workers. So they were able to answer any questions in terms of the consent process, and we linked in, as you would imagine, with our sexual health team, so we knew that we had a referral pathway in place for any of our HIV or our syphilis positive cases. And then the challenging bit was that lovely Excel spreadsheet where you have to try and make sure you've got enough people to cover the days. So we're similarly, we had 2 people there at all times, and that was a combination across our health protection team, from our clinical hepatology team, and also with GDAS. And we also decided that to reduce the admin burden, we were going to deliver negative results by text message. So that was also something just to work through, ensuring that we had that as part of our consent process and made sure we had the correct phone numbers and all of those things. So what happened? So we didn't screen quite as many, but I'm going to take that. We screened nearly 140 people. Most of whom were male, just to say that we had to think about how people reported in probation settings. So we had a women only section, which happened on a Monday morning. So just thinking about how we made sure that we had the right staff who were able to staff that. So we screened 140 people. As I say, most of them were men, and around a quarter were in that sort of 35 to 39 group. What did we find? We found essentially a hepatitis B, a hepatitis C, and a syphilis. So all of those were followed up by telephone, and they were entered into the correct clinical pathway. Sexual health services were involved, and we had the negative results, as I mentioned, were delivered by text. So what we would try to do was to try to understand, we wanted to make sure that we were giving that active offer. So interestingly, the setup was slightly different in Newport, so we didn't have quite the ideal just off the reception room, and that highlighted itself within the first couple of days as being a bit of a barrier. So what we did was we got our health protection, I say we, this is all royal we stuff, as you can imagine. So our health protection team went out and actually went to support that process. So they were there so when we had the testing guys who were in the testing room, we then had an additional member of staff who was able to be in the reception area to have conversations, to give the information leaflets, and to try to make sure that we felt that we were giving a really proactive offer for each individual who came through. So we were, huge thanks to our probation colleagues for this, but they have gone through the sign-in sheet for us and have identified that there were 657 unique appointments over the course of the 4 weeks that we were there. So we had an uptake of around 20%, 21%. It varied hugely day to day, and it varied through the course of the pilot as well. So we actually saw quite good uptake for the first couple of weeks, and we did then see a drop off in terms of the number of tests in week 3 and week 4. Some of the days, say on Monday, for example, we saw really high uptake for the first 2 weeks, dropping to nearly 0 for weeks 3 and weeks 4, which we're assuming, well, one of the assumptions is that relates to the fact that these are people who are presented again, so therefore they've already had their test. But what we did do was, and this is where I get all a little bit public healthy, our health protection team tried to explore with individuals who refused what the reason for that referral was. So what we wanted to do was to be able to develop some insights into the barriers that people were experiencing. And then we utilised some behavioural science tools for us to be able to think about, well, what do we need to do differently in order to address those barriers? So most people, unfortunately, didn't take up the offer. So of those people who didn't take up the offer of the test, we asked around nearly 60 people as to the reason why. And mostly people said that don't really want it, not interested, so didn't really give a huge amount of detail. But we were able to sort of bring together some sort of broad themes that might have been previously screened. It might have been the lack of financial incentives, or they were planning to do it in the future. But what we did was we looked through, we've gone through and tried to understand that using a behavioural analysis tool, which is called the COMBI model. And essentially what that looks at is the different things that trigger us to behave in a certain way. And they can broadly be grouped in terms of people's capability, and that can be your psychological capability, your physical capability. It could be the opportunity that you have to enact a behaviour, and it can be your motivation. So when we try to sort of group those things together, we can see that there were issues around psychological capability. So that might be around misconceptions about transmission, not perceiving people themselves to be at risk because they didn't think that they'd fitted any of those sort of high risk behaviours. There was issues around what we would group around that opportunity. So people might say, well, I can't do it because I'm about to, I'm homeless and I'm not going to be able to receive that result, or wouldn't be able to manage in terms of what the implications would be for me. And for others, it was around more broadly around motivation. So that was often around the lack of a financial incentive that they may have received in another testing environment. We've also undertaken we're in the middle of the evaluation, I think it'd be fair to say, so this isn't all complete, but we've done a staff survey, which is looking both at probation, clinical staff and the support staff who've been involved. So this is just some very headline figures. So the top one is just looking at how they would score the whole pilot from a scale of 1 to 10. I'm going to take 7. That's all right. It's above 5, room for improvement, but it's not a negative. The others are a marker around how well prepared people felt, and that's a marker out of 5. So people felt fairly well prepared. They thought more importantly that it was valuable for people to have BBV testing within the probation setting, and they thought it was an appropriate place for people to be tested for BBV as well, which was really important. So what would we do next time? I think that having our probation staff being even more aware of what we were doing, why we were there, why they could help, helping them to have conversations with people on probation would be really helpful. I think clearer information being provided for people, more simple, easy read information would be really beneficial. And it was really interesting to hear this morning that talk from guys from the Hepatitis C Trust, just thinking about, you know, we had professional staff having those conversations. Would it have made a difference if we'd had peers, people with lived experience being able to talk through? So that's a really interesting point for us to reflect on as well. We'd also like to broaden the offer of STI testing. So ideally, we wanted to be able to provide the take-home testing kits for people who, to be able to, if people refused it or didn't want a DBS test or didn't want to have all of those tests. So we'd be able to broaden our offer. And we also want to think about which days we would want to be there. So there were some days of the week where there were lots more appointments, and there, as a consequence, we had lots more testing. So if we were going to do this in a more sustainable way, would we want to be targeting on a particular day of the week? Building on from what we found from that sort of the behavioural change elements of things, so we can help to improve their capability by providing that information in a way that is really helps to identify what people's risks are, their perceived vulnerability, so why they might be vulnerable. We can also think about the motivation for people by thinking about having conversations about the pros and cons of testing. So actually saying, well, this is why you could do it, this is why you couldn't do it, working through those processes, and also thinking about incentives. We also need to think about how we provide that social support for people so they don't feel that this isn't an opportunity for them at that moment in time, but actually this is something that can be done for anyone at any point in time. So in terms of our next steps, we're looking at formally evaluating that. So as I said, we're midway through sort of gathering the data for the survey. We need to think about what a sustainable model looks like. Obviously, what we have done is gone in as the health board with working together with GDAS. But actually, what we need to think about now is how we then develop a sustainable model so that this high intensity testing event can then be continued going forward. But there was generally really positive feedback around this, and I know that our probation colleagues are really keen for us to think about other areas within Gwent that we could go, with Caerphilly potentially being an area. And I know that they're also in conversations with many other health board areas to think about how they could test in those settings as well. And from my perspective, we're also really interested in making sure that we can think about how the probation delivery unit can be used as a venue for other forms of health and wellbeing promotion and interventions. So as I mentioned earlier, this was a bit of a royal we conversation. Huge shout out to Gavin for all the work that he's done, providing the treatment for those individuals and coordinating and generally just keeping us all on track. Our colleague within the probation service, Sadie, who's been fabulous, as well as our GDAS colleagues and our health protection team, particularly our sampling and testing team, who've gone out and undertaken all that testing for us. Thank you.
Okay, questions for Bethan? Nikki?
That's a good question. Yeah, that's a good question. It would seem, and I think it's the ability to be able to know that people are there and be able to follow them through in order to be able to deliver that full schedule seems like an opportunity. So yeah, it's a start of that conversation, isn't it, around what we can or can't do within that setting. Politicians answer that one, wasn't it?
Yeah, that's good. Stephen.
Incentivise testing going forwards, you know, even if it's a, you know, from a Mars bar through to a Greg's voucher.
So Gavin will probably be able to respond. We do have incentivized testing in other settings. So that was one of the, there's outreach work within our homeless teams where there's incentivized testing there, also within particular clinics which are set up for sex workers. So we already have incentivized testing in other areas, and that was probably one of the balances that we had. So we had people who said, oh no, I'm not gonna have it done here because I'm going to go along there and I'll get my voucher there. So we just need to think about some of the consequences of incentivizing and how we make sure it's balanced so we're not missing out on opportunities.
I'm going to declare a bias here and say that I think we shouldn't be doing incentivized testing anywhere basically. And the reason I think that is exactly what you're highlighting here is, whilst it can temporarily increase motivation, there are negative consequences. And there's actually scientific data to show that if you incentivize people, you get decreased motivation once that incentive is no longer available. So in the long term, I think it's a mistake. I appreciate people won't agree. I think Kieran is going to disagree, but go on, Kieran. Well, I wasn't expecting you to come up and hit me.
Yeah.
Has there been any work to check if those people have been tested or their testing is up to date within the last 3 to 6 months? But then that just means they were tested elsewhere, doesn't it? That doesn't mean they were necessarily lost to a screening process.
Yeah, no is the honest answer. So these numbers are really small in terms of the people who gave that. The overwhelming response people had was, oh no, I'm not interested. And it was interesting what Morgan mentioned about the ripple effect, because that was definitely something that was felt within was that people had, with one person said no, then the whole room said no, and then you couldn't, no one would then. So I think so it's fairly small numbers. We didn't follow up those individually, but our colleagues who know those individuals would be able to know whether or not they've been tested or not. So yeah.
Danny?
Yeah, just comment about incentives. I mean, we run incentives, not in all our projects. In fact, I did a bit of a crude audit with our point of care SEPED testing lead in Birmingham. We've got 5 SEPED machines in Birmingham that our peers use. He never uses incentives and has a higher rate of engagement as people who do, right? Nonetheless, people do seem to value the incentives, but once they're in, they're happy to tell their mates. And I think there's something here from a public health point of view, accepting some of the arguments against it. We're in a rush. We don't have an awful lot of time to get these people in, all right, and get them kind of tested. So from a pragmatic point of view, I kind of tend then support to it. Does that make sense? But it's talk to all of our peers, and they will always say it's a tool. What really counts is their relationship with that individual. And if I reflect back to this year, when I used to do outreach work, HIV outreach work in London many years ago, we always used cigarettes. There was always something that we would give. If I remember, it's not that.
Don't tell me that. Come on.
So once I think
I'll be out there with my Help Me Quit team.
10% of the regulations, there's no doubt one of the reasons so well.
I think,
Getting rid of legacy and having community is working better.
And I think one of the things that did come back through some of the feedback from the staff that we started to receive is not necessarily does it have to be a £10 voucher. It could be something much smaller than that, and it doesn't necessarily have to be a large incentive. It's just some way, almost as you say, it's about starting that conversation, starting that and developing that relationship.
Louise?
In your probation project was when we were down in Swansea testing, we were told we would have potentially access to about 2,000 people on the caseload. So we were kind of geared up for that amount of people, but then we 2 weeks into the project, discovered lots of people that actually seen at home, so they have their probation appointments at home. And we've recently been to probation in Cardiff and Vale, and we've handed out the home testing kits. But so it's just something I think we wish we could have considered, and for other people to consider going forward. That some people you can't have access for some people because they're seen at home, and perhaps we can have access to the home testing kits for the probation officers to give those out. To be able to offer everyone who accesses that service. So
Absolutely. I think that the home testing kits would just be another layer. It won't go into the detail of it, but it got a bit complicated by the time we were trying to introduce that within this pilot. The other thing just to say is that on reflection, we could have utilised the fact that on some of those days, so like a Wednesday, for example, they had other things happening. So there were other groups going on. So they might be a group in relation to sort of people experiencing domestic violence, whatever it might be. There was some sort of something else happening which brought more people into the unit on that day. So I think it's about developing relationships again, isn't it? Knowing how that works, we'll know that for next time, so we'll know that we need to think about that more. So it's utilising. This is all about, isn't it, testing people who are already in contact with another service. So at what point, when's that maximal? It's maximal when people are coming in for a variety of other things apart from just their appointment.
Okay, probably one last one because it's Morgan was up ahead of you. Sorry, Josie. Morgan.
You're asking them for a BBB, which they might not seem like it's relevant to them. So they might likely say no.
But I think that one of the cases that was detected, if I remember correctly, was somebody who wouldn't have been in contact with any other services, hadn't had any testing in the past. It was and would otherwise have had an undetected, undiagnosed infection. So it was definitely we were reaching people who weren't otherwise being reached. 2 of them.
Excellent. For the people online, that's 2 people who are picked up who wouldn't have been picked up otherwise. Okay, almost to time, just a little bit late, and that's probably because I threw a hand grenade in at the middle. But thank you to all our presenters. Again, just to make the same point, it's the people that are delivering what we need to deliver. So thanks to everyone, thanks to Beth, and thanks to all our other speakers. Enjoy your lunch. I'll see you at 1:30. Get some networking done.